Hello everyone. Today we're going to talk about hemophilic arthropathy. My name is Brittany McCrell and I am joined by Ashley Aikman, Kristen Dugan, and Rebecca Hogan, and we are PT students from Texas State University. Etiology. A good way to conceptualize this condition is knowing the stimulus is blood, the target is the joint, and the result is arthropathy. A person lacks a specific clotting factor listed below which causes bleeding into the joint. Joints are repeatedly exposed to metabolized blood products. Presence of blood in a joint causes deterioration of the tissues, leading to chronic synovitis, articular cartilage damage, bony hypertrophy, and subchondral cyst. Hemophilia is more common in males, as you can see, and the majority of those, about 75 to 90%, will have hemoarthrosis, which is actual bleeding into the joint. The knee, ankle, and elbow are most common, with the knee being the most prevalent. This is a picture demonstrating the altered blood flow in hemophilia. Symptoms. Pain, decreased motion, edema, and ecchymosis are common things that you will see in these patients, and as you can see in the pictures, it is pretty debilitating. Functionally, these patients will have decreased movement, leading to gait deviations and difficulty with ADLs. Patients will hold their joint in the open pack position to reduce articular pressure.
Imaging is critical in diagnosing hemophilic arthropathy and in staging the severity of the condition. Conventional radiographs are used for the initial assessment, but MRI is the best choice overall because it can detect synovial and cartilage changes throughout all stages of the disease. In this radiograph, you can see periarticular osteoporosis, epiphyseal overgrowth at the asterisks, widening of the intercondylar notch, and joint surface irregularities. This is an image of severe hemophilic arthropathy. Notice a large complex joint effusion in the top left and the amount of synovial hypertrophy and fibrosis in the joint. The Arnold and Hiltgartner radiographic staging model is used to stage the severity of the condition. Stage 1 is the first acute bleed. As the condition worsens, the amount of soft tissue changes and joint disorganization increases. It can progress all the way to stage 5, where the joint is completely fibrotic, contracted, and requires a joint replacement. While hemophilic arthropathy is usually diagnosed based on the patient's history and imaging findings, here is a list of conditions that may present similarly to hemophilic arthropathy, mainly due to the increased amount of inflammation they cause. Common surgical options include synovectomy, removal of part of the synovial membrane, arthroscopy using an arthroscope, arthrodesis, which is artificial induction of joint ossification, and arthroplasty, where a part of the joint is replaced with a new mechanism. Multiple studies utilized this method and resulted in an improvement in range of motion and function, decreased pain scores, and corrections of flexion contractures. It is also important to note that physical therapy should be initiated prior to and following surgery due to the complications associated with this condition. Patients may opt to undergo multi-joint procedures due to the decreased cost and 54% reduction in clotting factor consumption, though it is important for patients to understand that more extensive rehab is required. The prosthesis survival rate following arthroplasty is 90% after 5 years, with infection being the most common complication. Infusion of purified factor replacement is among the most common treatment methods for individuals with hemophilic arthropathy and can be administered episodically on an as-needed basis or prophylactically, which is regularly scheduled. In addition, injection via hyaluronic acid or rifampicin can be utilized to improve the state of the joint.
Bleeding tends to occur when shearing or damaging forces are applied to a hemophilic joint. Therefore, physical therapy should focus on providing stability to the joint through strength, range of motion, and cardiovascular exercise. When addressing strength, parameters should be modified according to the disease level associated with the target joint. During the initial eval, the patient's baseline strength is assessed using a dynamometer. The maximum isometric strength established by the dynamometer can then be used as a reference when determining an appropriate strength intervention. A level 1 strength intervention should be used with extremely fragile joints and should only involve activities that use 40% of the patient's dynamometer strength at baseline, or 1 rep max. If a patient has not had any bleeding episodes for 6 consecutive months, activities can involve up to 50% of 1 rep max and up to 60% if the patient has minimal to no signs of impairment. Each level of strength intervention should use one set of 10 reps and should only be performed within the pain-free range. If no pain or swelling is present, intensity may be increased by 5 to 10% per week, but no more than 75% of the 1 rep max. Range of motion is appropriate for all patients, but should be gentle, low load, and use a prolonged hold of 2 to 20 minutes. Cardiovascular exercise parameters are based on the patient's maximum heart rate, or 220 minus the page. During the first 2 treatment sessions, endurance activities should remain below half of the patient's max heart rate. Cardio activities can then be progressed by 5 to 10% of the max heart rate if no adverse effects are reported, but they should not exceed 70% of the max heart rate. Endurance activities should generally last around 20 minutes. This slide summarizes how to progress a patient that has just been referred to physical therapy immediately after a bleeding episode. During the acute stage, pain is present at rest and with all activities. Appropriate interventions include rest, ice, compression, and elevation for 10 to 20 minutes, and immobilization with a splint. The patient is non-weight bearing at the point, so gait training with an appropriate assistive device is indicated. The patient has progressed to the subacute stage when pain is still present but not exacerbated by ADLs. Rice for pain and after exertion is still indicated, however, the patient should now be weaned off the splint and progressive weight bearing begins. Active range of motion and progressive strengthening of the target joint are also initiated at this stage. Once pain is completely free, even with ADLs, the patient has progressed to the chronic stage. Range of motion and progressive strengthening of the joint are still indicated, and modified activities and sport-specific exercise can be introduced at this point. The patient should be reminded of the importance of activity and how to minimize shearing forces and thus the risk of joint bleeds from physical activity. Up to 60% of adolescents with hemophilia refrain from physical activity out of fear of future joint bleeds, which impacts longevity and quality of life long term. Therefore, patient education is very important for addressing such fears to promote safe return to physical activity. The following 3 slides summarize the research findings on hemophilic arthropathy interventions performed between 1989 and 2006. These tables should be referred to if you need ideas for possible PT interventions for your patients and the efficacy of such interventions for small patient outcomes. Some possible complications that can result from hemophilic arthropathy are primarily decreased bone mineral density, or osteopenia, and decreased muscle mass, or sarcopenia. Osteopenia can result in osteoporosis, which increases the risk of both fracture and future bleeding episodes, since Nadiri 2012 found a significant correlation between the number of bleeding episodes that occurred in the past year and the amount of decrease in bone mineral density experienced by the patient. Sarcopenia occurs in 17 to 40% of hemophilic patients, which destabilizes the joint, thus increasing the risk of future bleeding episodes. Patients with hemophilic arthropathy tend to be less active, which both creates and exacerbates these 2 complications. Therefore, patients who adopt safe exercise practices into their lifestyle have a decreased risk of both osteopenia and sarcopenia and their associated risks. The following 2 slides provide general guidelines to keep in mind when approaching the plan of care for hemophilic arthropathy patients. The most important guideline to remember is to prevent compressive shearing forces and to avoid overexertion of the joints. An individualized exercise program of strengthening, flexibility, and cardiovascular exercise tends to result in significant improvements in joint range of motion, strength, and distance walked. The clinical bottom line is that hemophilic arthropathy is a condition that can be managed with conservative and treatment factor replacement therapy. A multidisciplinary approach should be used, and physical therapy treatment should aim to reduce secondary impairments and to prevent long-term sequelae of the disease. Surgical intervention should only be suggested when conservative measures are no longer effective, and PT should be used both before and after the surgery. These are our references.